I'm a gastroenterologist by profession, and I left India 40 years ago, and it's been wonderful to see the gradual improvement in healthcare in India. About 17 years ago, I started Project Echo in the United States to solve a particular problem that people were dying because of a lack of specialty access in the country. In my own clinic, I had an 8-month wait to see me, and people were dying from liver cancers and liver failure because they couldn't get treatment for hepatitis C. So I developed Echo with the idea and our mission to exponentially expand the capacity of a health system to implement best practices all over the world. And the way the Echo model worked was that we would use one-to-many video conferencing like we are using today to leverage the expertise of a multidisciplinary team of experts. And we would share best practices, protocols, guidelines with primary care clinicians. And then they would present patients to each other and to us at the university. And we would build communities of practice. And what we found was over time, these primary care clinicians became experts, and waits in my clinic fell from 8 months to 2 weeks. Since then, we have now expanded the Echo project from hepatitis C to more than 70 different disease areas in 158 countries. We have partnered with the Honorable Secretary Preeti Sudan in India, and have launched almost 50 networks in India, including our work in India on COVID-19 has involved the training of 300,000 healthcare workers on best practices in COVID-19, which have included nurses and doctors and public health professionals, etc. And in the last 12 months have done 66 million minutes of training in India. But going back to the more general, what we've found across the world is that there's an enormous shortage of skilled healthcare workers in every country that we work in. Even in the United States, where we have almost twice the specialists than any other developed nation, and almost 50 times that in some countries in Africa, our rural patients don't have access to specialists easily. Our low-income patients cannot find specialists. Primary care is difficult to find. So over the last few years, there's been a quantum improvement in healthcare in India because of the Ayushman Bharat project, which we will hear about in a moment from Mr. Indu Bhushan. One of the challenges, the insurance arm of this project has, of course, relieved a lot of suffering for humanity, and many, many visits have occurred. Yet there remains a challenge of healthcare workers shortage, skills of healthcare workers. And we know that the right knowledge the right care cannot be provided unless the right knowledge exists at the right place at the right time. So in our work around the world, we have found countries taking 3 primary approaches for the purpose of overcoming healthcare resource shortages. First is, of course, you can take the approach of making a lot more doctors, more medical schools, make nurses, more nurses. This takes a lot of time, but has enduring benefits. Another approach they've taken is allowing mid-level providers, from barefoot doctors in China many decades ago to nurse practitioners and physician assistants. The approach we have taken around the world is there is existing workforce, why not upskill them? That is primarily the way Echo works. We find when a nurse has a repertoire working on a license allows 1 to 10 level of work, most of them work at 3 and 4 because they don't have the skills. And so Echo has taken the approach of upskilling them, building communities of practice in which all teach and all learn. I want to now move on to our panel and introduce our first speaker. Dr. Indu Bhushan is, of course, well known to all of you. He's the Chief Executive Officer of Ayushman Bharat. This is the Pradhan Mantri Jan Arogya Yojana of the National Health Authority, the world's largest government-funded health insurance scheme, providing cashless secondary and tertiary care to more than 53 crore poorest citizens. He's a civil servant turned economist with a career spanning nearly 37 years. He has had multiple positions with the Asian Development Bank, including as Director General, Strategy and Policy Development. He was awarded the Government of India's National Award for E-Governance 2019-20, the Gold Award on behalf of the National Health Authority, and also the Global Achievement Award by Johns Hopkins University, his alma mater. Please welcome Dr. Indu Bhushan. And Dr. Bhushan, you will have 6 minutes to speak. Thank you. Please go ahead.
Thank you very much, Dr. Arora, and thank you very much for inviting me here. And of course, this crisis, pandemic has been a huge tragedy for the country, for the whole world. But in this perspective, I want to make 3 points. First, while this tragedy has been there, it has also thrown up some opportunities. And one opportunity is that health sector has become the center of debate in policy discussions. Earlier, health sector was on the periphery of development debates. Now, for last 6 months, I've never seen that health is being seen in discussions in the PMO, Cabinet Secretary, and all different ministries. So when we were saying earlier that health is everyone's concern, probably the first time all ministries are working on health sector. For the first time, we are seeing health sector issues being reported on the front page of all newspapers for a long time. So this is an opportunity that we need to seize, where we can put in place long-term reforms and changes in the sector, which will help us come out of this crisis better and stronger, number one. Number two, this crisis also has shown the fault lines where we have not done well. And I think that also points to where those changes need to be made. And some of those issues are that we need to do more for urban health. We need to do more for digital health. We need to do more in public health, and all these areas which have not received the kind of attention we should have given in the past have come back to, are showing us the mirror that probably these are the areas we need to work more on. Third, and I think this is a positive message, that many of the initiatives that government has taken in recently have also helped in a big way in responding to the crisis. And I'll focus on only the scheme that I supervise or coordinate, Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. And this has helped in terms of responding to the crisis in a big way and showing that schemes like this can build the resilience that we need in the health sector. And I'll just share with you 5 areas where the scheme has helped in doing that. Number one, it has helped in terms of protecting the poor from COVID and non-COVID, both diseases during last 6 months. We have provided through this scheme support for 70,000 tests and more than close to about 25,000 treatments. And these are to the people who have taken this treatment and tests. The private sector, they wouldn't have been able to afford it. Second is that the scheme also has been able to crowd in support from the private sector in a big way in terms of providing help, especially for the non-COVID. What happened in the past 6 months with the COVID, many of the hospitals scaled back their operations. Some hospitals actually closed because of lack of access, but also human resources problem. But our scheme has been able to continue and get more private sector hospitals. And last 3 months, we have been able to get close to 3,000 hospitals impaneled with us, providing non-COVID care. And the critical non-COVID care has almost not suffered during this because of this. Third thing is about data and the importance of data and the kind of the several 100 terabyte of data that we have also helped in terms of identifying the high-risk groups and people who have comorbidities, because clearly from their records, and getting in touch with them and providing them information, education. That has been tremendous. But also from our regular flow of information on what is happening, where influenza-like illnesses are coming up, where SARI-like illnesses are coming up, that can provide leading indicators or leading help for surveillance and seeing if the problems are emerging there. Fourth, the IT structure, the IT backbone that we've created helped also some states in monitoring not only PMJ COVID beneficiaries of what is happening, but also non-PMJ COVID beneficiaries. Many states asked us to expand our IT framework to help them monitor what is happening, support for the COVID. And finally, the call center that we created under the scheme has been able to provide an support for 1075, which is the lifeline for COVID help. And in last few months, we have fielded close to 30 lakh calls and integrated similar amount of calls to states. And so close to 60 lakh calls have been fielded through this. And this was also because of the digital call center that we had put in place, and it helped. So in general, what we see is that initiatives like this can help build resilience against any unforeseen attacks or medical emergencies. And so with that, I still feel that there are many areas, like I mentioned earlier, they need further support, and using the opportunity which has been given to us by bringing the health sector to the core of a policy discussion, we should be pushing on those areas. Thank you very much.
Thank you. Well, thank you, Dr. Bhushan, and thank you for your wonderful service, and congratulations on all your awards. And really, what a privilege to have you as leading this enormous initiative. Our next speaker is going to be Ms. Preeti Sudan, who's a friend and has been a collaborator for the last few years with us in the ECHO project in India. She was the Health Secretary of India till last month, where she's been a key strategist in times of the COVID-19 pandemic, a 1983 batch IAS officer of the Andhra cadre. She was previously Secretary, Department of Food and Public Distribution. She also served as Special Secretary, Ministry of Women and Child Development, and as Joint Secretary in the Ministry of Defense. In her cadre, she has a distinguished track record of serving in finance and planning, disaster management, tourism, and agriculture. Ms. Sudan has been a very key functionary in the planning and implementation of the Ayushman Bharat Yojana. Welcome, Ms. Preeti Sudan. And please tell us about the critical bottlenecks and resource constraint in achieving universal healthcare in India.
Thank you so much, Dr. Arora, and so good to see you again. And thank you. I begin with many thanks for all the handholding that you've done for training our resource persons during this COVID time. And because we are talking about this, let me say that we have trained about 7 million people in this during these tough times, and this was very, very critical. So let me begin with the topic itself. We are discussing today building resilience in India's primary healthcare system. When I'm talking about opportunities and bottlenecks, I think I would first like to begin with what will make us resilient. Because if we are very clear in that vision, then we can identify our bottlenecks and also identify what our constraints are and how we can remove them. So in my mind, there are 7 key elements that will build our resilience. First is that we should have a very clear statement of deliverables. We are talking about primary healthcare. What are our target groups? What is the diversity that India has, tribal areas, hilly areas, difficult areas, inaccessible areas, then areas where you have specific diseases, like, we've been facing local epidemics also. So very, very clear statement of deliverables. Whether now we also need to move to the vertical, we need to merge the vertical programs horizontally. We have non-communicable and communicable programs separately, MCH separately. What's the platform? So a very clear statement of deliverables, number one. Secondly, of course, HR. You see the human resource element, doctors, nurses, lab technicians, epidemiologists, and so on. I just want to tell you that a lot of work has been done in India in this regard, whether it is on medical, PG education, or increasing the seats in undergrad or postgrad or specialist diploma courses now started by DNB. So there's been a lot. That's a matter of a separate video conference. But what I want to point out is that we have now started with the health and wellness centers, community health providers. That is the main thing. Because when you're talking about primary healthcare, then community health providers and community medicine is one thing which needs to be worked on, which will make us resilient. It's being done in health, in education also, medical education, and actually today we have about 44,000 community health providers in place in our health and wellness centers, which I'll talk in a minute. Second is that adequate training and regular updation of skills of these workers. Then fourth is motivation to perform, both monetary and non-monetary. You've seen our ashas. This is performance-based, payments, and a lot of prestige and respect they have in their villages. So that makes the difference. You feel that you are a part of this social enterprise. Then, of course, adequate infrastructure, equipment. It's not about buildings only. It's about how the services are also delivered. Then next is very close monitoring and feedback. Why I'm saying this is because you see the scenario is evolving. So we need to keep learning and reinventing ourselves. If we don't do that, if we become stagnant, then it doesn't help. Next is, of course, social audit. We must have social audit of our health services. For health and wellness centers, we have put in place that social audit will be done by the self-help groups in the villages itself. So accountability is very important, and accountability has to be not by a big organization. It has to be by people themselves. So where are we now? As you know that since pre-independence, actually, we had this vision of a very robust primary healthcare system, very comprehensive, and Bhore committee did outline that. National Health Policy of 2017 spoke about accessible, affordable, quality healthcare within a paradigm of ethics. However, we did not translate it into a program. It has been done with Ayushman Bharat with two pillars. One is the PMJ, and the second is the health and wellness centers. And I'm so glad that we did it this way, because then the entire paradigm of healthcare we have covered. And now with COVID, we have seen how important it is to have a robust public healthcare system. So in our journey so far, it was MCH, mother and child services oriented primary healthcare till now. The vertical programs dealing with communicable diseases, with non-communicable diseases. Non-communicable diseases, mind you, was largely ignored. You are part of our TB vertical program also. And then now with health and wellness centers and PMJ, this is the first time that we are talking about comprehensive, preventive, promotive healthcare. So I want to emphasize that India's primary healthcare system can become resilient only if the preventive and promotive aspects of healthcare are also integrated. You spoke about USA. USA spends 18% of its GDP on healthcare. But just look what's happening during COVID. You don't have outreach workers. You don't have anything to reach people to. So that is what I think India has done right. and we need to build on it. So I again want to repeat that health is a public good. We must recognize that health is an individual responsibility. We've not, sort of worked on that. So, and health is not just absence of disease, it is wellness. And I think the Prime Minister's message, which he gave in, in the health, in the General Assembly of United Nations also last year, very, very clearly said that for us, it is preventive and promotive healthcare. It is wellness that we want to bring into healthcare. So that is why I want to also emphasize that health ministry cannot do health alone. So the Ministry of Women and Child, the Ministry of Panchayati Raj, Rural Development, then you see this Swachh Bharat Abhiyan, Eat Right movement, Fit India movement, the Gram Swaraj Abhiyan, the way the multi-sectoral, you see field level and middle level and higher level ministries have converged. That is what we need to build on. That's what will make us resilient. When I talk about these things, I'd like to say, how do we institutionalize this? It's very easy to speak about these things. How do you translate it into actual reality? For that, I would like to say that there are few steps. Let me begin from the very, from the field level.
Thank you. Please end in about 30 seconds, just because we want to give the other speakers some.
Okay. So then you should have warned me earlier. You didn't give me the time in the beginning, I think. Okay. So just to say that all the field workers together will work, and we need to leverage technology, our e-Sanjeevani, our telemedicine, your Echo platform, recognize good work. We are today digital health mission has been announced by the Prime Minister from the Red Fort. We'll take that forward. So this is what, in my view, will make primary healthcare resilient. Thank you.
Well, thank you, Secretary Sudan, and happy Independence Day to all. It's a pleasure to introduce our next speaker. Dr. Devi Shetty is the chairman and founder of Narayana Health, a cardiac surgeon with 34 years of experience. He's world renowned. He's also the initiator of the micro health insurance scheme that led to Yojana scheme, world's cheapest comprehensive health insurance scheme, set up by the government of Karnataka, which benefits millions of farmers in Karnataka. He's the recipient of a number of awards and honors, most noteworthy being the Padma Shri and Padma Bhushan awards conferred by the government of India, and the Rajyotsava Seva award conferred by the government of Karnataka. Welcome, Dr. Devi Shetty. Please talk to us about the role of public-private partnerships in resolving the bottlenecks in our health system.
Thank you. 5 minutes.
We have 6 minutes, yeah.
Minutes, okay, fine. Thank you so much. Thanks a lot for the opportunity. On the 6th of August, that's a few days ago, Government of India came up with a Gazette notification, which has essentially liberated higher medical education. The impact is that the single step by our government will transform the way healthcare is delivered across the country. And today, our indicator of healthcare, we are at 112 position below Iran, Iraq, Venezuela. I am very convinced in 5 years, we will reach one of the top levels. Why this transformation will happen by single regulation? It is because every year, 170,000 young doctors, passionate doctors, appear for postgraduate examination entrance test. Out of them, not more than 30,000 of them get their postgraduate seat of their choice. And the remaining 110,000, 120,000 doctors do not go back to work in a government or a private hospital. Instead, they head directly towards Kerala or Kota to attend coaching classes, to mug multiple choice questions for the next 2 to 4 years to 5 years with the belief that one day they will get that elusive PG seats, which they never get because they don't exist. But with the new liberation policy, government has done the cleverest thing by introducing diploma courses, which is a 2-year diploma course, not the 3-year diploma course. The advantage of that is if they introduce a 3-year course, all the big hospitals, government and private, are already saturated with postgraduate residents. By introducing diploma courses, few thousand government hospitals and private hospitals with 100 bed, 200 beds can become postgraduate institutions. Our biggest problem today, we are in this mess because entire countries, government hospitals have a shortage of 80% for medical specialties. I'll give an example. Women and children comprise 60% of the country's population. They need a gynecologist. There are only 30,000 gynecologists in the country. They need a pediatrician. A country which produces 24 million babies a year has less than 30,000, 40,000 pediatricians. They need the support of a family physician. We have a shortage. They need radiologists to do the imaging. There are less than 10,500 radiologists. So government hospitals were virtually not contributing to healthcare. Now with this training program happening, there will be a transformation happening because of the young, passionate doctors working in these government hospitals who will serve the patient and also become better doctors. Now, we have been hearing a lot about COVID problem affecting thousands of people, large number of people getting admitted to ICU. And we heard so much of debate about ventilator. Everyone was talking about the ventilator, but none of us talked about a person called anesthesiologist who's going to link the patient, COVID patient, to the anesthesia machine. And they are called anesthesiologists. And there are less than 30,000, 40,000 anesthetists in the whole country. And half of them are more than 45, 50 years old. They're not comfortable in treating patients. So with the launching of this course, large number of private hospitals will be able to train huge number of doctors required. Similarly, large number of government hospitals. Together, they will create such a formidable force that about 1 lakh doctors who are not currently touching the patients will come back to touch the patients and serve the needs. And this will have a huge transformative effect. And the other huge transformative effect, these courses of higher education are virtually free. They don't need to pay any fees. Instead, these doctors, when they are working, they get handsome stipend so they can manage with their family. So this will encourage large number of children from poor families to join medical college. And why we want children from deprived families to join medical college? Because these are the children coming from poor families. What we notice across the world, doctors who have magic in their fingers generally come from deprived background. And those children in Indian context are not dreaming of becoming doctors because of the high cost. With the liberating higher medical education, there will be a transformative effect. And I'm convinced that India will become the first country in the world to dissociate healthcare from affluence within the next 5 to 7 years. I have no doubt about it. Thank you very much for this opportunity. Thank you.
Well, thank you, Dr. Devi Shetty. That was such an inspiring message. I think that, in Latin, we've always focused on exports. If we did what you said, it would. I've enjoyed reading your article, Beds Don't Treat Patients, Doctors Do. And I think it makes so much sense. And liberating people to do and follow their dreams. It also helps us economically. Healthcare workers can be a major export. As I said, we work in 158 countries. Everywhere there's a shortage. And Indian doctors are often considered the best doctors in every country that I go to. So I think that if you do what you're saying, it could have a huge impact. I want to now open this up for discussion. And I hope Preeti Sudan and Dr. Indu Bhushan, you can turn on your cameras too, and we can have a discussion. One very major challenge that is coming up that we are seeing all over the world was just last week in the US, we did a survey here, and people were asked this question: if a vaccine was available today for COVID-19, would you take it? And only 66% responded that they would actually take it. The second issue for us is that 7 billion people will have to be vaccinated all at once after about 7 months. Between 7 months and a year, a vaccine will be here. It'll be mass manufactured. The question, and most countries that I have been talking to don't have the trained healthcare workforce to motivate patients, to tell them what the side effects are, why they should take it for themselves, how will it benefit their family, how will they manage side effects. I wanted to offer we are doing this in Africa too, all across 50 countries in Africa, but I also wanted to offer this platform to India for training our ECHO platform, for training a workforce and planning now for vaccine delivery that is about to come in India. If you could also comment on this, of how we should move forward in this area, and also other things in relation to what you've heard from each other speakers. Let me go to Dr. Indu Bhushan first.
Yeah, I think administering this vaccine to 1.3 billion people in the country will be a challenge. It will be a challenge from logistics point of view. It will be a challenge from how do you prioritize, who should get it first. And also, you rightly pointed out that we need to see how to deliver it, because if we want to deliver only through the public sector, then that will be a challenge, especially if you want to do it in a very short amount of time. And fortunately, Government of India is fully aware of these challenges, and there is a task force right now, as we speak, established, which is looking into all these issues, including how the vaccines will be stored, procured, stored, and delivered, and how the implementation will be monitored. And I have no doubt that this task force is going to have a very effective plan of action put in place well before the vaccine is available.
Thank you. And a question for you, Ms. Preeti Sudan. You can comment on this too. And also, I think you're muted still. I wanted to certainly tell you that if you decide to use the platform, we can help you train 1 million people if that was required in India. But the other question, if you could also comment as we go from speaker to speaker, Dr. Shetty has given this idea for post-graduation. But what is the harm in also training us thinking that we are going to become the healthcare provider workforce for the world, and really expanding in all different areas of a healthcare workforce? We already are a nurse exporter, and this is something college education Indians like to pursue. Is that an opportunity for us too, in the economic sense? Ms. Preeti Sudan.
Just quickly on vaccine, there is a committee, a high-level committee, which has been formed with Dr. Paul and Secretary as co-chair. They are working out every nitty-gritty of vaccine. You see, once it comes, how distribution, storage, transportation, and definitely, I think you should send an email to Secretary. I will also tell them that your platform should be used. I'm sure it will be used, Dr. Arora, because we are using it in our healthcare training anyways, number one. Number two, on what Dr. Shetty said. So I'd also like to tell you that there is a allied health professionals bill, which was actually to be introduced in the parliament, but it sort of, because the parliament got postponed because of COVID. Therefore, this is a game changer. We will be, because we will regulate all health professionals across, you see, the spectrum of healthcare. It will really give a boost to, we will not only export, but we will also be able to have credibility. Today we see that nurses in US are from Philippines and all, not from India, because we don't have a very robust regulatory system, number one. Number two, Dr. Shetty actually has been in touch, and I'm glad that he has acknowledged what we have done for DNB diplomas. Now, everywhere in the district, each district can actually have a diploma postgrad student there, which will, he or she will not only contribute to healthcare, but also then work there in the long term. And there are a lot of things going on in healthcare. I think we should have a separate, dialogue on that. Thank you.
Thank you. And Dr. Devi Shetty, if you have additional comments, and I saw Mr. Mohandas Pai had also put his camera on. I don't know if you had a comment. First, you, Dr. Devi Shetty, and then we'll open it up for questions from the audience.
The Sanjeev, today IT products are one of the largest foreign currency earner in the range of, I think, about $150 billion, if I'm not mistaken. If we train 5 million doctors, nurses, medical technicians with the idea of them being prepared to get a job outside India, and 5 million workforce can easily remit $100 billion a year, which is almost as big as the largest revenue generator IT industry. And this, we have to do it. The reason is, across the world, there will be shortage of nearly the more than 12 to 13 million healthcare workforce in the near future. When that kind of a workforce shortage happens, what the first world countries will do is to open their doors. Then all our doctors and all our nurses will fly away in a very short period of time, because there they get exponentially higher salary than what we have. It's an existential threat for India not to look at the healthcare needs of rest of the world. And we have to reorganize our training program so that they can easily pass those entrance exam and get the suitable job.
And Dr. Devi Shetty, that's exactly the point I was trying to make to you, is everywhere I go, there is a huge sucking sound from other places to for healthcare workers. If we expand our nurse practitioner, physician assistant programs, primary care doctor programs, specialty programs, we can do what we have done in IT, and exactly this could be the biggest export we can provide to the world. Because mostly not because of the fact that it's an export thing. That's what Indians want to do. It's their talent. They enjoy it. Indian doctors and nurses are recognized all over the world. And it offers an amazing opportunity for us to lead the world and provide service in that area. I think we have about 6 minutes more left in this panel. Santosh, are there questions from the audience that we should be taking, or should we continue our discussion for the 6 minutes? If you could just chat us and tell us what the answer is. But Dr. Indu Bhushan, do you have any comments about what Dr. Devi Shetty said just now?
I think this is the issue also Ms. Preeti Sudan also touched upon. Issue of human resources and ensuring that we have human resources at different level available for our own country, but also for the whole world. I think, again, I have a strong conviction that Government of India, I think, is on the right track on providing these human resources and developing these human resources through a lot of initiatives and policies which have been put in place in the last few years. So I think we'll see some results in coming years. And I think I'm very hopeful that we are on the right track in this direction, Dr. Arora.
Thank you. And Dr. Preeti Sudan, how do we incentivize our doctors in rural areas that have to work in rural areas, because currently there's no access to quality medical care? Somebody of our audience asks this question. Could you just talk a little bit about that?
Two things come to my mind immediately. First is that under the NHM, we have a policy of you quote, I pay. So we ask the doctor to actually quote, and we are paying in rural areas of Bastar and even in Northeast almost 2 to 3 lakhs per month. We ask them to quote. Number one. Number two. Recently, MCI and Government of India have notified compulsory district internship for our postgrad students. So this will come into force from next year, from this coming year. So that also will ensure that there is an incentive there. Next is for the community health provider in the rural areas. We are. It is again 20% is the monthly salary that is given. Next is performance based, and thirdly, under the NMC bill, as you said, the nurse practitioner will be given powers to actually practice community medicine. So these are some of the things that come to my mind. Thank you.
Thank you, Susan. And Dr. Shetty, just one, could you just address this question a little bit about rural? In some countries, what they do is, because lots of people want to become doctors, if the government has medical schools where people can go and get a medical school education at low cost, why could they not also have an associated rural sort of commitment to go to a rural area for a certain period of time? This is a uniform practice in many countries in the world. Is that a possibility for us to encourage people and sort of have a quid pro quo? And this will be the last question, after which we'll just do wrap up. Please go ahead.
Yeah,
Shetty.
Yeah, Sanjeev, we have about 500 medical colleges, and they have a massive campus, which is perhaps the largest campuses. I don't think many countries in the world have this big campuses and the infrastructure.
Okay.
And they are allowed to take about 100 to 150 students per year. Now, we have about 700 district hospitals. Now, these district hospitals should become part of the medical colleges. Each medical college should be asked to double the number of seats. The preclinical training happens in the campus. Clinical work, they go to the district hospital. And this is where they get trained. So straight away from 60 or 70,000 undergraduate seats in the country, you have double the number of undergraduate seats at virtually no cost to the government. And once you convert a district hospital as a medical college, nursing college, paramedical college, entire concept of delivering healthcare in the district will change. The students doctors don't go to remote locations for the sake of money. They go there for the training. I did my first job in Leeds in TB sanatorium because of the degree and the training they will give.
Thank you. No, I think first of all, I want to really so honored to have this chance to moderate this panel. Thank you all for coming. I want to wrap up by saying some of the key conclusions that we've had. The first is, it is necessary for us to expand our healthcare workforce at all levels. This can serve our communities in India. It can prevent an exodus, which will unnecessarily occur if we don't do that expansion. Second, expansion of the specialty workforce and the nurse practitioner program that Preeti talked about and you talked about. I think this is an amazing thing which will help us a lot. I think we need to, as you said, prepare much more for vaccine delivery and make sure that the workforce is there so we can stop this epidemic cold at that point when the vaccine is there in India. Our performance has not been quite as good as many countries in the world. And as far as ECHO is concerned, we are willing to offer our platform at no charge to anyone in India who wants to use it for the benefit of the people of India. And so thank you all again. And thank you to the organizers for giving me an opportunity to be a part of it. Bye-bye.
Thank you.